Good evening, webinar participants. Thank you for attending our educational event this evening on case studies and practical tips on incorporating OCT angiography into your practice. My name is Renato Antolovich, and I am the Zeiss Product Manager for the Retina and Glaucoma portfolio in Australia and New Zealand. Together with my co-presenter, Dr. Robert Chong from Southern Ophthalmology in New South Wales, we hope to give you a deeper understanding of the technology and applications offered with OCT angiography. Zeiss Angioplex OCT angiography was first launched in 2015 on the Cirrus 5000 OCT. At the time, it provided new vascular insights with ultra-clear 3D microvascular visualizations powered by the patented OMAG-C algorithm and utilizing the fast-track eye tracking feature of the Cirrus 5000. It provides clinicians with an enhanced workflow with non-invasive, dye and risk-free angiography with just a single capture. At the present day, Angioplex OCT angiography is available on both the Cirrus 5000 and the brand new Cirrus 6000 model. The Cirrus 6000 bringing faster workflow, a new HD version of the Angioplex scan, as well as a larger scan size. The Cirrus 6000, which was launched in late 2019, offers a new 100,000 scan speed, utilizing the same spectral domain platform. It's referred to as our performance OCT of the portfolio, and it achieves OCT scans with the scan speed 270% faster than previous generations. With OCTA, it offers an improvement of 43% compared to the previous generation, and it captures the everyday macular cube and optic disc cube scans in as little as 0.4 seconds. With the Cirrus 6000, your clinicians will be able to see more and also with more detail. The unit offers expanded field of views with OCT and OCTA scans out to 12 millimeters in size, as well as the HD version of the Angioplex scans in both the 6x6 and 8x8 scan size for those needing high resolution in their OCTA imaging. The unit also brings a new 2.9 millimeter scan depth. You might ask how the Angioplex technology actually works. Well, what it does is it detects the motion of scattering particles, such as red blood cells, in the vessels, and it scans these sequentially with sequential B scans performed repeatedly at the same location of the retina. So in a cube scan, it will start at the very first horizontal line location, repeating that scan either 2 or 4 times before it moves to the next parallel location. And it's these cluster of B scans with the OMAG-C algorithm that's responsible for the data processing that gives the clinicians both a cross-sectional B scan color-coded with blood flow, but also a reconstructed map of the perfused vasculature within the retina and choroid, as we can see on the right-hand side. The Angioplex maps are a 2D representation of the retinal vasculature of a particular region or depth of interest. The 3 most common maps commonly referred to would be the superficial retina map, outlined here, the red box, and as can be seen in the anatomical slice, in location or depth number 1. So it may be too small to see in this image, but the purple lines in the B scan that suggest the top and bottom border of this region or depth, defined as the superficial retina, it is within that depth that the flow is shown just above. Likewise, a little bit deeper in position number 2 in the anatomical map in green, we've got the deep retina map, which is made up of the capillaries of the deep retina. Thirdly, the avascular map, traditionally found in the 3rd location, number 3 on the left-hand side, is a region traditionally avascular in normal and healthy eyes, but can be compromised and present with neovascularizations in some cases. There is quite an extensive range of different maps and visualizations available in the Angioplex software. As mentioned in the previous slide, the superficial, deep, and avascular maps, but also sitting above the inner limiting membrane, and projecting into the vitreous would be the vitreoretinal interface, which might be good for those surface level neovascularizations growing in NVE and other conditions. But we've also got a color-coded map on the top right-hand side, which, using the red, green, blue colors mentioned in the previous slide, gives the depth perception with this color-coded map. Red being the superficial vessels, green being those from the deep plexus, and if there were any blue vessels on this, that would suggest vessels growing in what is deemed usually the avascular region. Deeper in the retina, we do have the choriocapillaris map and the choroid map, and in the later software versions, we released new segmentation areas referred to as ORC, or outer retina choriocapillaris, and Rpe to Rpe Fit, which can be used for a variety number of choroidal neovascularizations, as we can see, and I'm sure Dr. Chong will detail in coming slides. The latest version of the Cirrus Angioplex, available on both the Cirrus 5000 and 6000 units, offer Angioplex Montage visualizations. So the combination of between 5 or 6 individual scans stitched together to see more and to see this wider field perspective with OCT angiography. The final product will be presented either as a 10 by 14 or 14 by 14 millimeter montage image. Alongside that, the new applications potentially for glaucoma and other optic nerve head conditions would be the Angioplex analysis, both single visit as well as change analysis for the optic nerve head. And as we can see in the picture, the optic nerve head scan is optimized for the peripupillary area, and it looks at 2 factors, that being perfusion density and also flux index. So Dr. Robert Chong is a medical retina specialist in Sydney. He completed a medical retina fellowship at Moorfields Eye Hospital and is a consultant in the medical retina unit, Sydney Eye Hospital. He is a clinical lecturer at the University of Sydney and is in private practice at Chatswood Retina Service, Retina Associates, and Southern Ophthalmology. As part of the Outback Eye Service, Dr. Chong also runs a retina clinic in Bourke, rural New South Wales. It's with great pleasure that I now introduce Dr. Robert Chong and hand over to him for the rest of the presentation. Thank you very much, Dr. Chong.
Okay, thanks, Renato. First of all, thank you to Zeiss for inviting me to speak on OCT angiography, or OCTA. It's a newish technology that is becoming more and more common. More and more units, OCT units are becoming equipped with OCT angiography technology. I've been using OCTA for a few years now, and tonight I plan to share some cases with you on how I use OCT angiography in the retina clinic. So I'll broadly divide the cases into 2 sections. The first half would be on CNV and how I actually use it to diagnose or exclude choroidal neovascularization. And in the second half of the talk, I'll move into retinal vascular disease. And then hopefully, after about 40 minutes or so, we'll take some questions. Renato will throw a few from you at me. So let's kick off with CNV. So let's dive straight in. The first patient is a patient with dry macular degeneration. You can see large drusen. I've got my pointer here, so you see large drusen. Patient also has patches of geographic atrophy there and there. Interestingly, this patient also has reticular pseudodrusen. So you can see a network or reticular pattern of subretinal lesions in the supratemporal, but also the inferior macula on both sides. Just staying on reticular pseudodrusen, they appear as light dots on green reflectance and also on blue reflectance imaging. So if you look here, they look as like white dots And with infrared and autofluorescence, they appear as dark dots. And especially with autofluorescence, you can see the extent of these subretinal deposits. What's the clinical significance? They are associated with more advanced macular degeneration phenotypes like geographic atrophy and CNV. So if you see reticular pseudodrusen, you might want to follow these patients up a bit more closely. But this patient turned up with she was asymptomatic, and one of the OCT scans actually showed a PED there, some drusen nearby, but there was new intraretinal fluid. So the question is there CNV? Is there choroidal neovascularization? So I performed an OCTA, and this is the cysts in question, and this is the suspicious PED. So if there's red, red equals flow, so blood flow, flow of red blood cells. There is no flow within this PED, so I was quite comfortable that this PED did not represent choroidal neovascularization. But then the question is, what's the cause for these cysts? What's the explanation for the appearance of these cysts? So these cysts are actually degenerative as opposed to exudative. And they're degenerative. Often we see intraretinal cysts in association with geographic atrophy. And in this case, if I just move back one slide, we can see increased transmission of signal there below this PED, and that's due to loss of the RPE integrity. So this patient has degenerative changes, and the cysts are not exudative on OCTA. So over time, I've watched this patient now for 2 years, and those cysts have not changed. They've not increased. So this patient, it does look like has degenerative cystic changes as opposed to a CNV. So in this case, OCTA was quite useful. Next case, another patient with macular degeneration has come for routine review. His left eye is amblyopic, so this is the right eye, 6/9 vision, this is his better eye. He doesn't want anything to go wrong with this eye. So when we do autofluorescence, you can see a patch of geographic atrophy there. You can see some RPE changes and some drusen down here. This is his OCT on the right eye, which is his better eye. And what we see here is no hemorrhage, no fluid, intraretinal fluid, subretinal fluid, none of that. But he does have a slightly elevated RPE right here. And so this patient essentially has a shallow, irregular PED. The question is there choroidal neovascularization? He's got no symptoms, 6/9 vision, stable. He's just come for routine review, and we see this on OCT. So I performed OCT angiography, this with a 3x3 millimeter scan, and it shows flow, which appears red, within the PED. And this is the CNV that we see underneath that, within that pigment epithelial detachment. So this patient has a CNV that is lying under the RPE, under his right macula, but it's not exudative. It's not leaking. It's not causing bleeding. It's not causing any symptoms. This patient's completely asymptomatic. So I had a discussion with him, and I told him that in his better right eye, he actually has what appears to be a new vessel. And we decided to monitor it for now because there's no sign of exudation. So this patient was monitored for a few months, and then he started to get a bit of fluid, some subretinal fluid, a very small amount of subretinal fluid. At that point, he was still asymptomatic. So we had another discussion, and despite his lack of symptoms, he was quite nervous about his only good eye showing signs of wet AMD, and we decided to treat, and we treated him successfully with anti-VEGF, and we were able to extend him out to about every 10 weeks, and he's doing fine. Next case is another macular degeneration patient who is asymptomatic in the right eye, and you can see in on this OCT he has drusen and also a fairly broad but very shallow elevation of his RPE layer. So if you like, a shallow irregular PED. OCT angiography shows a rather large patch or area of neovascularization under that RPE with flow. Now, this patient was asymptomatic. This patient had no signs of exudation, no fluid, no hemorrhage, so we decided to watch this patient. And we're watching this patient closely every 2 to 3 months. This patient has not needed treatment yet. Next case. So now this case is a 67-year-old Asian male with some who was referred in by his optometrist with some changes in the left macula. So I'll show you the right macula first. You need to pay attention, by the way, to this case because it's a polling case. So there'll be a polling question at the end of this case. So you might want to pay a bit more attention to this one. So right macula, there is some RPE changes here temporally, some drusen. Left macula, some drusen supratemporally, and some RPE changes at the fovea. Right OCT shows some small drusen, intermediate drusen, small to medium drusen. Left OCT, which is the area of which is the macula of concern by the optometrist, shows this subfoveal lesion, dome-shaped lesion, small. There is no fluid, there's no overlying fluid, there's no hemorrhage. And this is just another cut just above this one. So, polling question number 1. What is your diagnosis of this left macular OCT, of this left macula? Is it A, do you think it's a drusenoid pigment epithelial detachment, a drusenoid PED? Do you think it's B, a vitelliform lesion? Or do you think it could be C, choroidal neovascularization? So we'll open the poll, and if you can punch your answer into the computer. Let's see what everyone thinks. Is it A, PED, drusenoid PED? Is it B, vitelliform lesions? Is it C, CNV? So I'll just go back to the OCT. What does everyone think? So it's a close race between A and B. 11% think it might be CNV. Okay, that's probably, so most people, 40%, 45% think it's A, 40% think it's B, and 12% think it's C. Well, I performed OCT angiography, and to my surprise, actually, I must agree with the audience. I actually thought it was probably just a bit of drusen, but to my surprise, there was actually a flow within that PED, and this is the appearance of the CNV. right there. So this patient actually has a non-extrudative CNV in that left eye. Again, because there's no extradation, there's no symptoms, we're following this patient up closely. So answer is C. Now, with coronal neovascularization, there's several types. There's type 1, which is under the RPE, and I've shown you a few examples of that. Type 2 CNV is when the CNV breaks through not just Brooks, but also RPE, and they form a neovascular network above the RPE, and that's on fluorescein angiography. We see that as a classic lesion, which is the type 2 CNV, and they light up early, well-defined, and they're more easily accessible and more easily visible because it's not hidden away by the RPE. So the type 1 lesion would be an occult lesion, and type 2 the classic. And this is an example of CNV. There's a bit of shram surrounding the CNV, a bit of fluid, but there's a little nubbin of a CNV right in the middle there. Type 3 CNV is when the neovascularization begins in the retina. So it's intraretinal neovascularization, and then from the retina it works its way to the outer retina, goes through the RPE, and can form a pigment epithelial detachment as well. So these lesions are also called RAP lesions, or retinal angiomatous proliferation. So this patient was, again, asymptomatic. There's a bit of a trend here. Asymptomatic patient, but on OCT, so there's a couple of drusenoid PEDs there, but on OCT, there appears to be a hyperreflective lesion above a new hyperreflective lesion above the PED, and some new intraretinal fluid, very subtle. OCT angiography shows flow within that hyperreflective lesion and within the PED. So, and that's it's pretty subtle. So all you see is this white dot here on this scan. So there's some intraretinal fluid, and so this appearance will be consistent with a RAP lesion or a type 3 CNV. Next case is a patient with central geographic atrophy, GA here, and you can see there's a hypoautofluorescence consistent with GA, and this patient's on regular Lucentis injections for wet AMD on this in this eye. The left eye has peripapillary CNV, which is successfully treated with Avastin. The patient's now asymptomatic. OCT on one of his visits, however, showed a very small, tiny slither of subretinal fluid at the fovea. And there is a very small elevation of the RPE, a small, very shallow pigment epithelial detachment. So I asked, that looks suspicious. I was suspecting CNV. I asked for an OCTA, and this is what I got. So this scan here shows, especially if you look at this en face image, shows a lot of motion artifact with a lot of horizontal lines going right across. So these are microsaccades, and it reduces the quality of the image. Now this OCTA en face image here actually is suggestive of something happening, maybe a CNV in the middle, but it's hard to be sure. So what I did was actually took the patient back to the machine and tried again. Instruct the patient not to move and try to get a better scan. So this is a better scan. There's still some movement artifact. You can see some horizontal lines going across, but the CNV lights up, and it's a lot more obvious now with less motion artifact. So this is something to bear in mind when you get an OCT scan. You want to try to eliminate as much movement as motion and movement as possible. So that's a 6x6 OCT A cube. You can, for more detail and better resolution, you can go for a 3x3 scan. So that the 3x3 would be my default scan for CNV if I'm looking for CNV. But I might get a 6x6 as well if I've got a large lesion. So if the CNV or the pathology, the PED, seems to extend to the edges or beyond the 3x3 millimeter scan, then I'd get a 6x6 as well. This is for macular CNV. Next patient has an AMD patient has geographic atrophy and disciform scar in the right eye, poor vision. The left eye has a patch of geographic atrophy, and the patient has symptoms. Fluorescein angiography shows a minimally classic lesion. So the classic component is this area here, and the occult component is surrounding that classic lesion. So this whole lesion is CNV. So this patient in 2010 had a course of anti-VEGF injections and responded very nicely. Take note of the GA in this infrared photo. You can see GA there and there, not much. Fast forward 9 years, and the geographic atrophy has now extended all the way around that central area of CNV. And with OCT, or B scan OCT, you can see there's increased transmission signal there, indicative of loss of Rpe integrity. Now, in this situation, when you do an OCT angiography, and this is an automated slab, the sub-Rpe slab, if you just looked at it, eyeballed it, you think, wow, this patient's got a large CNV that goes from here all the way across, taking up most of the macula. But what's actually happening is that there's segmentation error due to geographic atrophy, which is a common source of artifact. So if you've got GA, watch out for segmentation error. So the machine is meant to trace the Rpe layer, which is intact nasal, temporally or in the periphery here. It's intact. But when it hits GA, a patch of GA, it loses the trace of the Rpe, and then it dives down and tries to find where the Rpe might be. And that's when it goes into the choroidal layer, and it picks up choroidal vessels. And then it resurfaces over the CNV and then dives back down and picks up choroid before picking up the Rpe further out. So that's why it looks big. If we use the Rpe Fit Slab, which Renato mentioned earlier, what happens is the top segmentation line follows the patient's Rpe, and the bottom line is where the machine thinks the Rpe should be. So it draws a line, a straighter line across. And with this fit, I mean, there's still a little bit of segmentation error, but it gives us a better idea of the extent of the CNV, which is smaller, which is more central, and it has reduced the artifact from GA, geographic atrophy. So you might have to play around with different slabs to get a feel for where the pathology is. And in terms of CNV, the slabs, the go-to slabs for me are the ORCC, the Rpe to Rpe, the Rpe Fit Slab. You can also use the sub-Rpe slab for if there is a high PED. This patient presented, he's quite young, 41, Asian male, presented with distortion, sudden onset distortion in the left eye. Right OCT was fine. The left OCT shows this peaked PED and a multilobular PED. So if you see a configuration like this, especially this is almost 90 degrees in terms of its takeoff. So you sort of think this could be polypoidal choroidal vasculopathy, or PCV, and there's associated subretinal fluid as well. So my orthoptist saw that and thought, okay, Rob will most likely want an OCTA for this patient. The last patient that was a vein occlusion, so she thought, okay, Rob asked for 12 by 12, so that's what he had won for this patient. And yes, you can. It does. The 12 by 12 does delineate where the pathology is, but it doesn't give us enough detail. So a better scan would be a 3 by 3 scan. Now this is a 3 by 3 Rpe Fit Slab. So the bottom line, as I've mentioned, is where the machine thinks the Rp should be, and then the top line should be where the patient's RPE actually is, and then it takes the scan of flow in between those two segmentation lines. It's not perfect, and you can see that instead of following the RPE down here, it's actually gone further out and jumped down. But it does the job. It shows flow of these polyps that are sitting just right under the RPE, abutting the RPE, the undersurface of the RPE, and you can see the polyps quite nicely here. Now, where there are polyps, there's usually a branching vascular network, which is essentially an occult CNV or a type 1 CNV under the RPE. So often the polyps are on the edges of these of the CNV. Now, I found in this 3 by 3 scan that the ORCC outer retinal to choriocapillaris slab actually shows the CNV quite nicely. So this is a nice case that shows that for different parts of the pathology that you might want to use different slabs or different slabs to see the full pathology. You can just about make out something happening here, but it's a lot clearer with the ORCC slab. Next case is a patient with an Asian patient with hemorrhage and symptoms and scotoma and distortion in the left eye. You can see subretinal hemorrhage here. You can see there's this darkened area which is a sub-RPE hemorrhage here in a sort of nasal, involving nasal macula, peripapillary area. ICG angiography shows these polyps quite nicely. There is a CNV in the middle of these collection of polyps and these clusters of polyps, and this polyp here has blown out a pigment epithelial detachment. In fact, it's bled into it. There's like a fluid level with blocked fluorescence here. This is fluorescein angiography, and it shows a CNV right here. As you know, fluorescein angiography doesn't actually light up the polyps as well as ICG, and that's where ICG comes into its own. You've got fluorescein filling in this half of the PED. Interestingly, there is also a small RPE rip, which is leaking some fluorescein into the subretinal space. So OCT angiography, also OCT A can also show the CNV component in the nasal macula. This patient has a double layer sign, or essentially a shallow irregular PED, a very shallow irregular PED in that area. So what about? So I've shown you some examples of type 1, 2, 3, and PCV CNVs. What about CNV in other pathologies? So let's, I've got a couple of cases of myopic CNV. So this is a high myope, tilted disc, peripapillary atrophy, lacquer cracks, atrophy. Patient comes with subretinal hemorrhage at the fovea. Do an OCTA and it shows the CNV quite nicely. This patient did not require an angiogram, a fluorescein angiogram. For me, we proceeded with treatment, anti-VEGF, and you can see resolution of hemorrhage, Schrem, subretinal hyperreflective material, and a better delineation of the CNV itself, which is a sign that the CNV is actually responding to treatment. Another case of a myopic CNV, you've got peripapillary atrophy, you've got lacquer cracks, and this patient presents with hemorrhage. There is blocked autofluorescence over here. Fluorescein shows a blocked fluorescence by the hemorrhage, but there is a CNV next to it that leaks. OCTA, in this instance, shows the CNV quite nicely centrally. What about other types of CNV? Increasingly, we're starting to notice or take note of patients with focal choroidal excavation. So this is where there is a focal area where the choroid is thinned or absent, and the RPE dips down to into that area of excavation or loss of choroid. And this areas of excavation can actually be associated with CNV. And I've got a few patients like this. So this patient here has presented with scotoma symptoms, distortion, and has subretinal fluid and some subretinal hyperreflective material. But you get the impression that there is actually the RPE actually dips down here. And the RPE is also a little bit irregular and it looks a little bit detached. OCT angiography shows quite a nice network of CNV on one edge of the choroidal excavation. This patient was treated and responded well to anti-VEGF, and after following the drying out of the macula, you can see the choroidal excavation in a bit more in better detail. You can see how that RPE dips down and then comes back up. So switching gears, let's leave CNV behind and move on to the diabetic retinopathy or vascular disease. So this patient has got proliferative diabetic retinopathy with neovascularization at the disc bilaterally and has diabetic macular edema. Optos angiography shows widespread peripheral non-perfusion, peripheral retinal ischemia. You've got neovascularization peripherally at the disc and elsewhere. There's also some macular ischemia. The left retina is even more ischemic with neovascularization at the disc, a lot of leakage from these new vessels. So if you do an OCTA for these patients, this is a 3x3, you can see that the foveolar vascular zone, or the FAZ, the FAZ, is enlarged and irregular with surrounding ischemic patches. The left macula is even more ischemic, and it's nicely highlighted by OCTA. With the OCTA can also help in distinguishing collateral vessels from new vessels. So if you do an OCTA over the disc, you can see there is flow within new vascular tissue that is protruding into the vitreous space, not within the disc itself. On the left side, you've also got new vessels that are sitting on top of the disc in the vitreous space, but not in the disc itself. So this is another case, and there would be we'll be polling the audience at the end of this case, so one to pay attention to. So this is a diabetic. This diabetic patient had macular laser for diabetic macular edema. This patient I saw had a small area of neovascularization, which was confirmed on fluorescein angiography. This patient had some temporal macular edema previously, which I treated with focal laser. So not all diabetic macular edema needs to be treated with anti-VEGF. If they are non-central, they can be treated quite nicely with laser. So this is the polling question. So on routine review of the follow-up of this patient presented no symptoms, 6/6 vision, and when I look at this disc, I saw 3 red dots here. This is the OCT A from on that disc. So polling question: what is your diagnosis of this right eye? Is it A, moderate non-proliferative diabetic retinopathy? Is it B, proliferative diabetic retinopathy with disc new vessels or neovascularization? Or is it C, central retinal vein occlusion? I'll just go back up and we can start the poll now. So I'll just toggle between these two. Say A, moderate non-proliferative retinopathy. Is it B, disc new vessels? Or is it C, CRVO? Okay, everyone's going for B, proliferative retinopathy with new vessels. Now, the answer is yes, it's B. It's new vessels at the disc. But where are the new vessels? So the new vessels are actually this area here, this very fine bit of tissue, vascular tissue, that has flow in it. So it's got some red in it. But it's sitting in the vitreous space just above the disc, the disc tissue. So absolutely spot on, everyone. And yeah, new vessels on the disc. So changing gears again to vein occlusion. This patient's got disc collaterals at the disc on the right side from a vein occlusion. There's some hemorrhages still present. The angiogram, if you did fluorescein angiography, you know that it's not a new vessel because it doesn't leak. It's not neovascularization, so these are collateral vessels. When you do OCT angiography, you can see that these new vessels reside within the disc structure itself. So it's not sitting anterior to in the vitreous space, it's actually within the disc itself. This left eye, CRVO with abnormal discs, vessels, nasally and temporally. We weren't sure whether this was new vessels or collaterals. The OCTA shows these abnormal vessels, or well, these sort of vessels to be within the disc tissue itself, not in the vitreous space. So these are collaterals. So this patient doesn't need PRP. Now, final polling case. So this patient has CRVO, pretty bad CRVO. You can see there's extensive leakage, hemorrhage on fluorescein angiography. a severe macular edema, had one shot of Eylea, and the patient responded very nicely. The edema is gone. But the vision it remains at count fingers. So polling question number 3, why is the vision still counting fingers after all the edema is gone? Is it A, is it vitreous hemorrhage? Is it B, a sudden change in macular thickness? Or is it C, macular ischemia? So A, vitreous hemorrhage, B, sudden change in sudden macular thinning, I guess, or 3, macular ischemia. So I'll just go back to the OCT. So fire away. Let us know what you think. Okay, everyone's gone for macular ischemia. So let's scroll down. And that's correct, macular ischemia. OCTA shows almost absent blood supply at the center and the temporal part of the macula. You get a clue from the OCT itself, actually. Yeah, and even the pre-injection, pre-Eylea OCT, you can see that there is increased in the hyperreflectivity of the inner retina. And post-injection, there continues to be increased hyperreflectivity indicative of macular ischemia, and that's confirmed on OCT angiography. So another case of this right disc this is with some abnormal vessels here on the edge of the disc. Are they collaterals or new vessels? And all these vessels are within the disc, therefore they are not new vessels. So another case where after of central retinal vein occlusion, severe macular edema, after one shot, the edema clears, but the vision remains at count fingers. This is a 12 by 12 scan. So it's a single scan, non-montage, so it's just one take, and it shows quite a bit of ischemia in the periphery. It's better highlighted on this scan here. You can see there's quite a lot of closure, and but to get a better sense of the macular pathology or the circulation, I did a 8 by 8 high definition scan. And you can see that that macula is very, very ischemic. There's a lot of pruning of vessels, loss of capillary network, very ischemic. No wonder vision's count fingers. Now, a couple of cases of macular telangiectasia to finish off. So I found that OCTA is actually quite useful in MACTEL. This is type 2 MACTEL we're talking about. So with MACTEL, you get all kinds of vascular changes on OCT angiography. You get, first of all, disrupted FAZ. You get vessels, large vessels running across the FAZ. You've got right-angled vessels. These vessels that run towards the fovea should start to narrow, but these abnormal vessels don't, and then they can suddenly abruptly end when they dive into the deeper layers of the retina. So that's called a right-angled vessel. So these are features of MACTEL. There's another patient with MACTEL. There's temporal telangiectasia, dilated capillaries. There's these vessels that run across, that track across the fovea in an abnormal way. There's some of these vessels, they suddenly abruptly end when they dive into the deeper layers, and they anastomose in deeper layers. There's OCT B scan, OCT changes. There's some outer retinal and some inner retinal cavitation. There is some RPE changes as RPE clumping as well. So these are some features together with, between the B scan and the OCTA, often you can make the diagnosis of MACTEL. So, in conclusion, OCTA is quick, takes only a few seconds to do. It's non-invasive, no need for dye, no need for cannulation, no need for the risk of anaphylaxis, nausea, vomiting, etc. It's reduced, but it hasn't replaced the need for dye angiography, and I've shown you some examples of how multimodal imaging with FA, with ICG, and with OCTA can be used to understand the pathology better. Importantly, it allows a three-dimensional assessment of the different vascular layers, as opposed to fluorescein, where you get fluorescence from all layers and you see it on a two-dimensional scale. Whereas OCTA, you can separate out the superficial from the deep capillary plexus from the choroid. It allows detection of vessels that are not meant to be there, for example, neovascularization. It also allows detection of vessels of absence of blood flow where there should be blood flow, for example, in ischemic retina. There are some weaknesses, including the limited field of view, but I've shown you some shots, some examples of 12 by 12, and if you take a little bit more time, you can do even wider field montages of the OCTA. So that, I think that will improve with time. There's some issues with artifacts, but I'm sure with time these can be minimized or ironed out, or I've shown you some strategies on how to identify and correct these for these artifacts. Okay, so thank you very much for your attention. Renato, shall we move to the questions?
Yes, thank you very much, Dr. Chong. It was very insightful, and hopefully it gave our participants a really good and deeper understanding of the technology, as well as the applications that's offered with this exciting modality. So I'll put it out to the participants to submit their questions via the chat function. The first one that came through, Dr. Chong, was the question: do you perform OCTA on the first scan for all patients as a screening tool, or only when something is suspected?
Yeah, so the question is, do we do OCTA on all initial patients? I guess the answer is no at the moment. It may become yes in the future, but for now, the OCTA files are quite big, so I'm a bit mindful of storage. So we don't do OCTA willy-nilly on everyone, otherwise it'll chew up your server. Most patients get a raster of scans, a cube, a Mac cube, and if indicated, the orthoptist might come and speak to me and say, oh, have a look at the B scan, and do you think we need to do an OCTA? So, or sometimes they just go ahead and do an OCTA if they suspect. So they might do a 3x3 and a 6x6 if they suspect a macular CNV, or if it's a diabetic with a lot of pathology, they might do an 8x8 or 12x12 to view the perfusion in the periphery.
Perfect, that sounds good. The next question from one of our participants is, do all CNVs leak at some stage?
I presume you're referring to the non-extrudative CNVs that I presented earlier on. The answer is I don't know. It's a relatively new discovery, I guess you'd call it, because of, especially with the advent of OCTA, we're starting to do more and more. We're starting to recognize a lot of these patients sit in clinic and the CNVs just lie dormant and undetected because they, as you can see, the changes are quite subtle. So a lot of them just sit there, and they can sit there for months and months and not leak. So they don't necessarily have to leak. And sometimes I've seen patients where I've watched them and then they've started to leak, and I said, okay, well, you need to do an injection. Let's book you in, or would you have one today, or would you like to come back? And they say, I'd like to come back. And then they come back the following week or in 2 weeks' time and repeat the scan, the fluid's gone. And I say, actually, the fluid's gone. What do you want to do? Do you want to treat? I say, well, I've got no symptoms. Let's watch. And then we watch. So the fluid sometimes can wax and wane, and it's only small amounts of fluid. I call this like a minimally active CNV. The concern is, of course, if it suddenly bleeds. I think if I see fluid, I'd advise the patient to have treatment. But some patients may choose not to have treatment because it doesn't affect their vision.
Sure, thank you very much. The next question from one of our participants is, how can you tell from an extrudative to non-extrudative CNV? Is it based on the OCT only?
Well, signs of CNV activity are hemorrhage. So hemorrhage, you might, if it's a small hemorrhage, thin hemorrhage, you might not see it on OCT. So that's where your clinical exam, you pick that up on when you have a look in at the macula, you look for hemorrhage. So the other sign of disease activity would be fluid, be it intraretinal fluid, be it subretinal fluid, or subretinal hyperreflective material, SHREM. So those are the main signs of disease activity that we look for.
Perfect. We've got a question from Dr. Tony Kwan, who's asked, or who's stated, I use serial OCT angiograms to monitor the growth of diabetic new vessels before treatment and their regression after injections or retinal laser. Do you do that in your practice, and do you find that useful?
I don't. I haven't, but I think that's a very good way of tracking tracking the progress of your the response to your treatment, and to allow you and help you titrate, say, your anti-VEGF or your PRP laser. I think it's a good idea. I guess for now I use it to diagnose a neovascularization that I'm not so sure about, like in these cases that I've shown you, that these subtle cases. But certainly it would be a good idea and it'll be straightforward and simple. You just do an OCTA over that new vessel and hopefully see it shrink as your therapy works. Yeah, good idea.
Perfect. The last question that I've got here from one of our participants is, has your fluorescein numbers reduced since the introduction of OCTA? And has that introduction of OCTA allowed you to get angiography information on patients that you would otherwise wouldn't have time to, due to time constraints or other reasons?
Yeah. So the answer is yes. Say I've shown you some cases of, say, for example, the myopic CNV. If I do an OCT, if I can get an answer with OCT and OCTA, and I'm fairly happy or fairly certain with the diagnosis, putting everything together, then I would save the patient from having a fluorescein angiogram. But if I'm not sure, and sometimes you might not get a good OCT signal, there might be media opacity, cataract, cornea vitreous hemorrhage, and if the view is not great, the signal's not great, you might need to progress to actually doing angiography. But I must say that as the more I do OCTA, the more I learn and understand about OCTA, the less I've the less fluorescein angiograms I've ordered. What's the second part of the question?
The second part of the question was, go back to that. Has the introduction of OCT angiography allowed you to get angiography information on patients that you otherwise wouldn't have had the time to potentially get that information?
Yeah. So I showed you some examples of OCTA of the perfusion of vein occlusion, for example, CRVO. Now, there are some clinical signs that the eye is ischemic from CRVO. You can, and I've shown you the inner retinal hyperreflectivity, the fact that the patient's got poor vision, the patient might have an RAPD, there might be a lot of deep blood hemorrhages in the retinal periphery, there may be a lot of hemorrhages. So these are all signs of ischemia. So, or you might see some ghost vessels in the periphery. So these tell me that this eye is ischemic. Now, and I'd be fairly certain of the ischemia, and I might not actually proceed with a fluorescein angiogram in that situation if I'm convinced that the eye is ischemic, the retina is ischemic. But if the patient's going to get an OCT anyway, and it takes only a few seconds to get an OCT, let's say a 12 by 12 OCTA, I might get that 12 by 12 OCTA, as I've shown you in the case, in some of the cases. And yes, the answer is yes, that in a busy clinic, or the patient themselves might not wish to undergo an angiogram. And in that case, in those situations, yes, I would have obtained information about the vascular perfusion, which I normally would not have because the FA would not have been done.
Sure. The very last question from me, Dr. Chong, would be, given that a lot of our participants tonight are optometrists, what place do you see OCT angiography in an optometry setting, perhaps being the first line screening location for eye disease? Would that add value to any referrals? And what are your general comments on that?
Yeah, so the role of OCTA in optometry, one area that I can think of would be to incorporate OCTA in diabetic screening, diabetic retinopathy screening. So as I've shown you that in some of these cases, sometimes it's actually quite tricky to pick up neovascularization. So if either in the retina or over the disc. So I think if you added OCT angiography on top of, say, just color fundus photography, hopefully wide field, it might draw your attention to certain cases of diabetic retinopathy where there's not what we call the featureless retina, where there's not a lot of pathology, not a lot of hemorrhage, not a lot of hard exudate and cotton wool spots that might make you immediately want to refer this patient. But then if you add another layer of OCTA, especially around the disc and around the posterior pole, like say with the 12 by 12, and you look for any signs or sort of screen for signs of neovascularization, I think that would add another layer of safety and timely referral, enable timely referral of these patients.
Perfect, that's very helpful. Well, thank you very much for your efforts tonight, Dr. Chong, and all of that valuable insight that you've given to our webinar participants. It's been incredibly valuable, even for my own knowledge, being a non-clinician. So I really appreciate your time and everybody's time in participating with this webinar. So just some housekeeping tips. At the top of your screens, there should be a blue drop-down arrow that some extra resources can be found. So things like brochures, some literature in there as well, some white papers on OCT angiography and some workflow benefits with new OCT models available in the portfolio. So we encourage you to explore those materials, and also look out for the link for the multiple choice questions for CPD purposes that will follow this presentation. So thank you again, Dr. Chong, and all of the participants, and we look forward to seeing you out there in the industry. Thank you very much.